Hi, my name is Dr. Brian Gruber and I'm the founder of Integrated Orthopedics. Today we're going to be talking about a very common condition, tennis elbow, or what we also term lateral epicondylitis. So with the elbow, there are basically two sides to the elbow, the inside or medial side, outside lateral side. So tennis elbow is on the outside of the elbow, and basically the tendons that allow you, or the muscles that allow you to extend your fingers, extend your wrist, hook on to a common extensor on the outside part of the elbow, and that is, when that gets inflamed, that is termed tennis elbow. Tennis elbow is very common. In our clinics, we'll see, I would say, any week we may see 5 to 7 patients that have tennis elbow. Well, we think that tennis elbow is common just because it's the, we just use our hands a lot, and oftentimes we'll get in, funny positions, and it could sort of aggravate the elbow and aggravate those tendons. Tennis elbow primarily is a clinical diagnosis, so patients will come in and they will complain of pain on the outside part of the elbow. They don't have to play tennis to have tennis elbow. It does happen, but usually it's actually not related to tennis at all. The examination findings are pain directly over the elbow, so it's pretty point tender and it's pretty classic once you begin to see it and diagnose it. Some of the other classic findings are pain with resisted wrist extension, so we'll have the patient straighten their elbow and we'll prevent the wrist from going up, kind of like you're riding a motorcycle, get on the throttle, and resisting that, it hurts and it causes pain over the outside part of the elbow, and those are the kind of the classic diagnostic findings that we will see in tennis elbow. We can see with how quickly the elbow gets painful. It can be both. For example, maybe somebody's painting a couple rooms in their house over the weekend, and they begin to get a lot of pain in their elbow on Monday. We see that. But we also see patients that have maybe started a new job, and they're using their arms differently, and it's over a period of time, so maybe 2 or 3 months. Oftentimes it starts out as very mild discomfort, and then it can turn out to where it's fairly exquisite pain, meaning you'll see patients where they can't grip their coffee cup, or they have trouble opening their refrigerator, or anything higher level than that, just because their elbow hurts so much. We definitely see tennis elbow in more active people, so it's something that typically a very sedentary person does not suffer from tennis elbow. It's definitely in the more active patient population. So tennis elbow is always treated conservatively initially, and in my hands it really depends on the amount of time. So if somebody comes into the doctor very quickly, say within say maybe a week or so, I think that starting out with just an anti-inflammatory is very reasonable. Motrin, ibuprofen, naproxen, something along those lines. As the chronicity increases, so somebody say has had discomfort for 2 months, 3 months, 4 months, I think it's more challenging to treat that only with an anti-inflammatory. So in my hands, we start talking about doing guided injections of steroid. The beauty of that is it works quite well, quite fast. So you'll do an injection, and we do it under ultrasound because we're really able to see the area of the tendon and the area of inflammation. So we'll do the steroid injection. We don't put it in the tendon, but above the tendon. And then what I'll do is I'll needle the tendon a bit to stimulate what we call a blood response. That's for people that have more of a chronic type of a tennis elbow. Oftentimes we'll initiate physical therapy for more of the chronic case, in that there's oftentimes significant amount of shoulder dysfunction, which we don't always think about. But once you're not using your elbow right, then the shoulder is not used quite appropriately, and you can get into some bad habits and some weakness of the shoulder. So that's the value in getting patients into physical therapy, and ultimately, hopefully, prevent you from being back in the office for tennis elbow. I kind of liken it to a funnel as far as recovery, because the short answer is yes, most people recover we recover without any surgical intervention. I liken it to a funnel where you have a bunch of people that come into the funnel initially. So like I said, we use 5 to 7. Sometimes we'll see 10 patients a week with tennis elbow, and typically people get better and they're done when we don't see them again. With the injection therapy time. However, at the very end of the funnel, there are always a few people that come out of that that have done everything. They've done all the injection therapies, and they end up requiring a surgical procedure. Typically, with the surgical procedure, we like to obtain an MRI. So in my hands, I'll do 2 injections of steroid over a period of time. And once the patient has had 2 injections, that sort of is a trigger in my hands to obtain an MRI to really see what's going on with that tendon. If there's a partial tear or a high-grade tear, then what we do we do a surgical procedure, and it's a fairly minimally invasive procedure. It's outpatient. It takes about 20 minutes to do it, and it's a very small incision. And what we do after we go, not to get too graphic, but we make a small incision on the outside of the elbow. The first tendon that we see is called the EDC tendon, extensor digitorum communis, and that's not the problem tendon, but that's the first one we see. So we make a small incision in that tendon and we book it open. So the next tendon that we see is called the ECRB, extensor carpi radialis brevis, and that's the problematic tendon. So we actually excise the tendon where it hooks onto the bone, because that's why it hurts. And it's kind of like the appendix, where you don't just take the appendix out. However, if it gives you trouble, you take it out and you don't miss it. It's the same thing with the ECRB tendon, where we take that out and we don't miss it. So then we kind of roughen that area up and close the book, reattach the EDC tendon, and then close the skin, and we're done. From a recovery standpoint, patients are interremovable, so they don't cock their wrist up. That's what stresses that repair. And typically a full recovery from that is somewhere between 2 to 3 months. We like physical therapy typically somewhere, and we start that somewhere between 2 to 3 weeks after surgery, depending on the motion. So patients have unrestricted elbow motion, which is very nice. It's a very user-friendly procedure, because you're able to use your fingers, you're able to drive, it's not overly uncomfortable. Typically patients are not on long-standing pain medications, so it's really user-friendly and allows patients not only to feel better from the tennis elbow, but be able to resume normal activities fairly quickly. No, I think the take-home for tennis elbow is that the vast majority of these are treated conservatively with ultrasound-guided steroid injections. I will say that this is an area that we're excited about from regenerative medicine. We do a lot of PRP, platelet-rich plasma, so that has the potential to heal these tendons, which we're excited about that.